with the exocervix and how it will look in a biopsy sample. So as you can see, the epithelium is okay. So epithelium is stratified squamous epithelium. What does stratified means? Stratified means layers. So you can see layers. This layer is different, this layer is different, this layer is different. So all that. And whether do you see keratinization over it? No, we cannot see anything pink amorphous material. So there is no keratinization. So it is non-keratinized stratified squamous epithelium. And in the basal layer suggests base. So what does basal layer consist of? Basal layer is a very simple layer with very beautifully cohesive cells. No atypia. Mitosis can be there, but that won't be atypical. And as the layers increase, like as we go up, cytoplasm will contain a lot of glycogen, and that's why in biopsy they appear white. So there will be a nucleus in the upper layer and more white area in the cytoplasm, suggestive of glycogen content in the upper layer. So do not confuse this with coilocytosis, which is which identifies with HPV infection. Here you can see that cells are really benign, beautifully there together as friends, and there is nothing you can say that okay, something is wrong in the cervix. Just the glycogen part you can see, and that's it. What is a transformation zone? Transformation zone is where there is one zone of squamous and then columnar. So the transition from squamous to columnar, from ectocervix to endo, this is the transformation zone, and it looks like this. So most of new pathologists, like people who have entered pathology and reporting a cervix, they get confused whether it is something malignant or is it dysplastic. No, it is not dysplastic. As you can see, the cells are pretty monomorphic. Monomorphic means of like one, like very benignly there, nucleus is okay, and yes, there is glycogen content here and here, but that does not mean that it is dysplastic. You can look for other cells, and if they appear okay, then must be a transformation zone which you are looking at. Do not confuse this with dysplasia. And there is no mitosis, their delicate membranes are delicate, round nucleus, and also there is no hyperchromasia. But observe this, remember this, so that you do not report this as dysplasia, because once you write dysplasia, further investigations for the patient, you actually do that to a patient if you report positively for dysplasia. So just if you think that okay, something is wrong with the transformation zone, and it is looking little uneven, atypical, then at least write that there is whatever your findings are, and then query transformation zone. Query, if you think that there is more dysplasia, then at least low grade dysplasia you write, but at least know that transformation zone can mimic a dysplastic epithelium, so at least mention it there. So because if surgeon has touched the transformation zone in biopsy, she will know that okay, I have given a sample of transformation zone, so I was expecting this, and it is not dysplasia. So you are actually saving the patient from further investigations and invasive procedures. Again, as we have seen this transformation zone in the previous slide, there is another mimicker of cervical dysplasia, squamous atrophy. Okay, so this squamous atrophy, it's you will see that epithelium is quite thin. There's nucleus is bigger than the cytoplasmic area, so the high NC ratio. But as you can see, they are dormant. They are not, pleomorphic. They are not screaming out as if they want to get some attention. In like in dysplastic cells, you will see that nucleus will be it's like It will be screaming out of the cell that look at me, look at me. They are just normally lying nicely, benignly, very friendly cells you can see here. But yes, definitely there is squamous atrophy. Mostly in postmenopausal women you can find this and can mistake this for cervical dysplasia. Don't do that. Correlate with the age of the patient, and if patient is 50 years or more, and please take the history of menopause, and if there is a history of menopause and also bleeding and you find this, then definitely you can report this as squamous atrophy instead of dysplasia, which will be incorrect in this case. Look at the cells individually, like cytology. You will find cells are very friendly, nice, very, very subtle. Okay, not screaming at all that look at me. They're not asking for attention at all. This is a very common case you will see in your pathology practice, especially if you're setting up for a histopathology center. Endocervical polyp. First of all, you will look at the epithelium. This is not a squamous epithelium, it's columnar. Okay, so single line of columnar epithelium with lot of blood vessels. All these small blood vessels you can see. So this structure is highly vascular, and look at the shape, the whole shape of it. The shape itself is like this. So must be a polyp. So first you look at the shape, then you look at the epithelium, and then you look at the vessels. And inside the stroma will be quite benign. Stroma will be benign. Okay. So your clue will be blood vessels and epithelium and shape. And if you see this, you can think about endocervical polyp. Epithelium will give you a clue whether it is malignant or not. In this, you can all see that cells are beautifully lined in a very basal way, and they are not going haphazard. They are not doing pseudo stratification. They are not screaming for attention. They're just lying there, resting nicely. So this is endocervical polyp. Okay, so diagnosis will be endocervical polyp. Kindly correlate clinically with your surgeon or a gynecologist who has sent you the sample, because that will help you a lot. This is an endocervical polyp in higher magnification. What do you see? I see columnar cells beautifully lined up in a very benign way, as if there is a symmetry to them. Okay, and yes, you can see that mucin collection is also there inside the cell. So here, okay, because of mucin collection, nucleus, they are pushed upwards instead of down. They are pushed upwards, or they'll look displaced. So this mucin inside the cell, along with the columnar cell epithelium and single layer, there is no stratification at all. If there is any stratification, we can still consider reactive changes to it, but double, triple layer, then you think more towards another etiologies instead of just a benign endocervical polyp. And as you can see in the whole screen, there is no atypia at all. I don't see anything. And yes, there are a lot of blood vessels, as we have already discussed. There are blood vessels, yeah, and inflammatory cells will be plenty. Mostly endocervical polyp, they come with a lot of inflammation. So lymphocytes and plasma cells, it will be there, and you have to report it. So whenever you find some inflammation with endocervical polyp, you can write endocervical polyp with inflammation. Yeah, you can mention it, it's fine. Or maybe it can be a part of chronic cervicitis, because you have not seen ectocervix, so you won't know. So at least write that features of chronic cervicitis along with endocervical polyp changes. As you can see here, as we were talking about these cells, we have already mentioned that these are benign cells. Blood vessels we have mentioned, but this blue sheet of inflammation, lymphocytes, if you magnify, you will find plasma cells as well. maybe foci of neutrophils because of bleeding. Yeah, so if there is bleeding, you will find neutrophils as well. So report it as endocervical polyp with inflammation. That's it. Another polyp which is called as decidual polyp. So this mass is will be given to you. So if you see these structures, as you can see, they're like squamous kind of cells with abundant eosinophilic cytoplasm and very clear membrane, like you can see here. So as if you are seeing a pap smear in histopathology, something like that you will feel. These clusters, all these are decidual stroma. Okay, take the history of pregnant women, take the history of exogenous hormone if any, and you will see this. And once you see it, and the structure you received was a little polypoid in nature, then you can definitely suggest decidual polyp as one. Second, pregnancy. Third, Arias Stella's reaction, all that. Old pregnancy, retained pregnancy, anything. But just use the term pregnancy so that you are safe medico legally. Because once you see this, either decidual polyp, if it's not a polyp, then it can be anything related to pregnancy, old, new, anything. So write everything in differential diagnosis as decidualized stroma. Reason can be any, but write the findings very clearly so that you rule out the confusion and keep yourself safe medico legally. Now in this you will see that there is a lot of benign proliferation of endocervical glands. Like instead of one, there are three in the same space. So do we say that okay, this is something malignant? No, because I can't see any atypia, I can't see any mitotic activity, and yes, there is hyperplasia, there is proliferation, but it's all benign. So in this case, we will ask the patient or the surgeon for the history of pregnancy or exogenous hormones if the person is taking any. Whether she's taking it or not, if you see such proliferation of endocervical glands, you can report it as microglandular hyperplasia. Whether you see it, observe it at one focus or foci, multiple focus, then you just report it, because sometimes it can be a clue that there is some hormonal thing happening to the patient. In India especially, patient, they do have the tendency to hide what are they taking. A lot of people, they take something and then do not tell the doctor as well. So if you report this, then at least the surgeon or the gynae will be helped. So if you see such benign proliferation of glands with endocervical epithelium, mucin inside, no atypia, stroma is there, maybe inflammatory cells will be there, then you report it as microglandular hyperplasia. Now, when we talk about cervical biopsy, we cannot miss HPV infection. So, because mostly the cholestatic changes or anything related to cervical cancer, HPV has to be considered. Whether it is high grade squamous intraepithelial lesion or invasive carcinoma, HPV is related. It is related to squamous cell carcinoma of even vagina, vulva, anus, penis, anywhere, oropharyngeal locations also, oral biopsies. So, and there is acuminata condyloma, low grade squamous intraepithelial lesion, as you can see. So what are these infections and what are the relevant ones? Like there are over 200 HPV types, but what are we looking for? We are looking for low and high oncogenic risk. What is oncogenicity? It is the capability to create or capability to develop cancer. So cancer developing capability is called as oncogenicity. Okay. Now, when we for us in clinical practice, we go for 16 and 18 mostly. but 31, 33, 35, these are to be looked for. So remember these, or just jot it down on some paper, put it in your on your desk or wherever you report your cervical biopsies. But you have to do this. And if you, in a cervical biopsy, if you see HPV related changes, do not forget to mention in your comments or a pathologist suggestion that you have to go for HPV DNA PCR. Patient should go for this, and the technique is to take the LBC sample, and then this LBC sample will be taken for HPV DNA PCR. It will be processed for low oncogenicity and high oncogenicity, and we are looking for 16 and 18 mostly, but other types should also be considered. So HPV DNA PCR should be suggested if cervical biopsy exhibit any coilocytic changes or any kind of dysplasia. You cannot miss this. Let's see, is it LCIL or HCIL? So again, the divide the whole squamous epithelium into three parts and see where is the dysplasia happening. Here I will say that 90% of it is happening in the basal layer. So lower one third is affected with hyperchromasia, loss of polarization, I can see, and crowding. Yeah, it's touching the middle one third, but not much. So I will spare using the term HSIL, spare myself from using the term HSIL here, and I will say that this is, I am dealing with LSIL or low grade dysplasia. I will say this, and for upper one third I'll comment that yeah, I am looking at coilocytes here. So for that I will write query HPV and then HPV DNA PCR. Again I will write. So again, this is about the thickness. So if you are seeing major changes in low one third and not in upper two third, then one third changes are dysplastic more than the two third of epithelium, then we are dealing with LSIL. And but if you see that instead of just this part is also covered with dysplasia, then without any doubt you can write HSIL. Write it, no problem. Write it. Better to overdiagnose this than avoid it, because you actually saving a life by this. What do you see in this slide? You see a basal layer. Let's divide the screen into basal layer and the upper layer. Okay. So what do you see? I see there's little crowding in the basal layer. I see crowding of the cells. They are not looking very friendly. Something is disturbed in the cohesiveness of these layers. These layers are not benign or lying dormantly happily. They are trying to scream. They are like asking for attention. You look at me, look at me, look at us, something like that. You see, especially in this area, you will see something is disturbed. Their uniformity is disturbed. So I see hyperchromasia, I see loss of polarity, I see lack of cohesiveness, and high NC ratio as well, especially in these area where there's a lot of crowding happening. And in upper layers, what do I see? I see a coilocytic change. Now, how do I differentiate this from the glycogen content of the squamous epithelium, which is normal in the cervical biopsy? I will say that look at the nucleus. In coilocytes, there is a perinuclear halo which can be confused with the glycogen content, but that nucleus is like pinpoint, very small, benign, friendly. But in this, nucleus is screaming for attention. It's big, like a resin. So we call it resinoid nucleus also. It's a weird nuclei, yeah. It's not something which you can just avoid. You just look at it and you know that's okay, something is wrong. And it's screaming out as if it's an eye, so that weird thing is a coilocyte, and this coilocyte will indicate that something is about HPV. So if you see this picture, first report it as dysplasia, low grade dysplasia, because it is just involving the lower 1/3 of the epithelium. If it involves the whole epithelium, whole thickness, then it is high grade epithelium or H cell, high H cell, low squamous and high squamous. Okay, so and what else, you have to report HPV, query HPV, and suggest HPV DNA PCR. Both should be done. Report it as LCL, query HPV, and then suggestions HPV DNA PCR. Use the term in situ, that means it is still confined to the epithelium. Now, here you can see that there are changes in the gland, but the outside environment is still benign. There is nothing similar between these glands and the stroma around it. So, in situ means that there is no stromal invasion, there is no change in the underlying stroma. Okay, now what is adenocarcinoma? As the term suggests, adeno means gland and carcinoma means cancer. In situ means limited to epithelium in this scenario. Okay, so in this scenario, this is a cervical, endocervical gland. As you can see, this is endocervical gland, but look at the cells. They look very highly attention seeking, and there is crowding, there is loss of polarity, cells are going up and down wherever they want, and a lot of stratification instead of a single layer, and pseudo stratification. For example, these are single layer of cells which are good, which were seen in endocervical polyp. Then if there are reactive changes, then same cells will look like this because there is pseudo stratification. Like nucleus begins to exhibit itself in different levels. So there is a single layer, but nucleus is at different level, which leads to pseudo stratification. Pseudo means fake. Okay, but here as you can see that actually there are a lot of nucleus in one cell. So there are cells with lots of nucleus, lots of layers, and there is no friendliness between them. Every nucleus has its own direction to go, and hyperchromasia I can see. Now if you see this, then think of dysplasia. It can be dysplastic or it can be actually carcinoma in situ. Yeah, now as you can see that there is no mucin also, like the white space you see, it has decreased because of nuclear crowding. There is decreased cytoplasmic mucin. Instead of that, nucleus have become hyperchromatic. There is decreased NC, reversed NC ratio, and I see lot of discohesiveness. And a very particular thing about the nucleus here would be that they are cigar shaped, they are spindle shaped. So instead of just benign and small looking cells, nuclei, they have become cigar shaped now. Yeah, spindle. So when you see all these features, start thinking of dysplasia and even adenocarcinoma in situ, because that's what will differentiate a carcinoma, proper carcinoma, from an in situ carcinoma. Like how? Now after this, if you have seen the features, just straight forward go to the stroma. Look at the changes. Can you see any similar changes in stroma? Can you see anything carcinomatous in stroma? If you cannot, and if you see these changes confined only to the epithelium, just write adenocarcinoma in situ. Okay, but if you see even focus of stromal change, mention that. Maybe it is micro invasion, maybe, but if it is frank, then definitely it is a carcinoma with invasion, stromal invasion. Yeah, So this is adenocarcinoma in situ. And how did we decide? Because changes were limited to the epithelium. In this you will see that few cells are containing mucin. They are discrete vacuoles. You can see here these vacuoles of mucin are there throughout the layer of the epithelium, throughout all the cell layers of the epithelium. There is nuclear atypia, there is hypochromasia for sure, and mitosis is also there. Let's find out where is mitosis. There it is. Mitosis is there, and apoptotic bodies are also there. Where are apoptotic bodies? Here. Yeah. Yes. These are apoptotic bodies, and there is a mucin layer throughout. So not just here or just here or just here. No, throughout. So when you see this, you can mention that you see stratified. What is stratified? In layers? Mucin producing. Stratified mucin producing, because you see mucin in every layer, and because there is no stromal mucin thing, so you write intraepithelial lesion. Mucin does not say that it is malignant. Mucin does not suggest it is benign, so you write lesion. Stratified mucin producing intraepithelial lesion. And yes, if you see atypia, hyperchromasia, apoptotic bodies, you mention that, because it will be a different entity than adenocarcinoma in situ or adenocarcinoma or even endocervical polyp. So this is how we have finished the chapter of benign and pre-malignant lesions of cervix.